Hi, everybody from the Netherlands. We're just opening up. Give it a few minutes. Welcome again to the Icoplast webinar. It's going to be really exciting event today. We got the fabulous speakers lined up for you. So we're expecting 500, 600 people. About 1,500 people have registered here from all over the place. So use the chat function to say hi and where you're from, because it's a lot of fun to see the world coming together here. We'll give it 3 minutes and then we'll open it up. Anneke, nice to see you. Let's see, Arjen van Turnhout, a lot of people from the Netherlands, obviously, but also welcome to Dimitrios Kannakopoulos from Greece, I suppose. Vishnu Babu. Oh, and Georgios is here as well, Papa Giorgio. Iskander, hi to you. Jenny Inda. Let's see, a lot of folks. Welcome, everybody. Lars Steinstrasser. Hi, Lars. This meeting is being recorded. Hi, Mike Kek. It's being recorded. We'll give it a few more minutes and then we'll start the presentations. Søren Kunneker, hi. Toshiaki, good day to you, or good night, I suppose. It sounds like you're in the Asian regions. Asa, hi Asa, Etsander, good to see you. All right, so let's start today's great event. And first of all, thank you for sharing your time with us and for your excitement to learn and explore our specialty. When you talk about exploring, one of the things that is really growing and becoming more and more important in our specialty is lipofilling, and especially lipofilling of the breast. Implants seem to lose their attraction, and lipofilling is one of the techniques that is, of course, out there to use. I'm going to start with a short introduction of Icoplast. We have no financial support from industry, so we're independent. We do have member societies, so plastic surgery societies. Those are the members of Icoplast. That means that if you are a member of a society that is a member of Icoplast, you pay dues, so you're part of us. So keep your camera standby. I show a couple of QR codes. I used to be the secretary as well as the treasurer of Icoplast. I'm now board member at large. I am a member of the webinar committee, and I do some other board functions. I have no connections whatsoever to industry. I'm not alone. I'm a proud member of a whole group of people that's really active in organizing these webinars. So we're an international confederation, about 50 plastic surgery societies worldwide, which comes down to 20,000 plastic surgeons, which is the largest organization in plastic surgery in the world. So that means you are Icoplast, and we are here for you to learn, exchange and connect, but really we want to learn from you. So please join us, and if you want to do anything, get in touch. These are the social media platforms we're active in. So you can use us if you're a member society or your department is organizing something, get in touch, use our resources to organize a webinar, become a member of a committee, whatever you feel like, be in touch. So we try to get all the presentations on our YouTube channel, so you can look it up at a later time. We've got a couple of future webinars lined up on taking exams, coaching. Lipofitting is today, actually. Writing manuscript, hand surgery. Well, share us your favorite topic, and we can certainly work out something that you can organize, because we usually have about 1,000 registrations or more. So get in touch. Well, I've said enough now. So today we've got 1,400 registrants, and as you can see, you're from all over the place. You're from everywhere in the world. If you are a member of one of our member societies, you can ask for a certificate of attendance. We don't hand out CME accreditations, but you can certainly try get it done, because we're an official organization within plastic surgery. Interaction is key, so please use the Q&A function in the lower end of your screen to ask questions, or use the chat if you've got something on your chest that you want to get rid of. Please let us know. We welcome any interactivity. So the first speaker of today is Professor Angie Pielskowski de Grzymala. Difficult name for me, but we know each other since we were on the national board in the Netherlands together. He's been really active in Icoplast as well as the founding force behind the website. Put a lot of time and energy into it. We should be really grateful for Angie's work in this. Angie is really one of the world's leading experts in lipofilling of the breast. He's running a trial in the Netherlands, and he did a lot of studies on the safety of injecting fat into the breast mount. So he's going to talk about that. He's in Maastricht, the Netherlands, and he's a great friend of us all. And then Roger Khouri, he's an innovator, a scientist, a mad scientist, but most of all, he is a plastic surgeon. And if anybody has ideas and gets them into practice, it's Roger. And he's really a big inspiration to the world of plastic surgery. And we need more gems like Roger. We've been collaborating with Icoplast through his board work of the International Society of Plastic and Regenerative Surgeons. They've been selecting people that won the fellowship for the Award of Excellence from Icoplast, which is a amount of money that we can you can use to visit conferences and also to improve our specialty in general. So without further ado, let's have some fun. Please be interactive, and we'll start now with Angie's presentation, which I'm really looking forward to. I'll stop sharing my screen, Angie, and we're all in the same room here, so it's like a studio in in the Netherlands. So anyway, Angie, the floor is yours.
I have to be allowed to share my screen.
Oh, yeah, I'll get that done.
Should be in a second. Yeah, should be done right now. Okay. So first of all, Hinne, thank you very much for these flattering words and this beautiful introduction, which I don't think I deserve that much, but thank you. Yeah, let's talk about lipofilling and the evidence around it. So I'm really happy to see that there are so many people coming and want to listen about plastic surgery, because in my opinion, it's not the next big thing, it's the big thing around now. So we all need to know what we're talking about. So just to give you a short overview, I'll talk about what is the problem right now, what is the discussion that we are leading. We are going to talk about the safety of the breast, we're talking about the efficacy of lipofilling to the breast, and then we're going to have a bit about the breast trial itself. If you look just at the publications that have come into PubMed and Cochrane over the last 20, 25 years, you'll see that it's growing really exponentially. So the interest in lipofilling is great. People are really looking into it, and we all know why that is, because it has numerous advantages. It's the use of your own tissue, so you don't have any problems that we know from prosthesis. It's minimally invasive, and it has very, very few complications. And I don't know how it is for you, but in my practice, it's really, I wouldn't even know what to do if I didn't have lipofilling on my hands. I would tell many patients, well, I can't do anything about this. So it's really nice, and we use it a lot. For instance, for lumpectomy defects, you know, lumpectomy, okay, it's really nice to conserve the breast, but you should do it so that you're not completely, the figure of the breast is completely distorted. So you can use lipofilling to correct these defects where patients really have a lot of problems. Another thing is what we do in Maastricht a lot is autologous reconstruction with, for instance, deep flaps. And there you also see that the flaps may be too small, that you have contour defects in the upper pole or and the medial side. And then lipofilling as a secondary procedure is really helping out to bring mediocre or good result to an excellent result. And of course, what is done more and more in these times is implant reconstruction, because just putting implants in mostly results in an acceptable result, but patients want more, they ask for more, and then lipofilling helps to get also these irregularities, this step of defects in the cleavage, to correct them. So, but the thing about what struck me when I learned everything from Roger Khouri was the total breast reconstruction. When I saw it for the first time in about, I think it was 2008 or 2009, I couldn't believe that it's really possible. And I think that it's still in some people's minds that this is not possible, but it is. We are seeing it. We're doing it every day. It's really a possibility to reconstruct a whole breast. But we are leading a discussion, which is where somebody may think or may say, this is just too good to be true. This can't work out. And especially when then there are coming alarming findings from mouse studies, yeah, that somewhere there is an interaction between cancer cells and adipose tissue, and that there is even it's what's called the dynamic duo. And if you put everything into a mouse, then maybe if you have cancer cells in the mouse and you put adipose tissue there, then yeah, the cancer will grow. So this was something that gave a lot of reactions internationally, and which made it very difficult for us, especially in the beginning, to get some acceptance in the community to do this. So what is the theory about it? If you have your lipoaspirate, you can look at it and you have, everybody knows it, if you centrifuge it, you have up there the oil, the fat cells, and then in the lower part, the stem cells in the blood. And it's all about the stem cells, because the idea behind this is that if you use it and you put your fat and your stem cells back into the tissue, then you get the activation of these stem cells in the tissue together with an ischemic environment, because you put in cells that are not vascularized. And this leads, of course, to the secretion of cytokines and growth factors. And this leads, of course, to angiogenesis, something that is very good. But then think about if there is something, and this is a theory, of course, but something that is accepted, but think of a dormant cancer cell. And then is the question, is this oncologically safe? And this is the one side. These are the theoretical risks. And on the other side, you have the clinical setting, which we look at, and we have big studies from Macia, from Kronowitz, from Petit, which show that there is no local regional recurrence after lipofilling breast. And these people have really done huge amounts of patients and they don't see anything. So it's the question that we have to look at. But if we look at these studies really closely, then we see that each of these studies is actually individually underpowered. And their follow-up is only 2.5 years. And then even if we look further, then we have like this anecdotal case studies where we see that through a lipofilling where there was still cancer, that we really spread the cancer, that this is a possibility. So the only way to look at this in a proper way was to put all these studies in a mixer and do a meta-analysis. And that's what we did. We did a systematic review. We looked at all studies with breast cancer patients. We looked at exposure to AFT. We had control groups not treated with AFT as the control. And we looked at the local regional recurrence events. So let us just look at the safety data. We looked at 760 studies, and after a screening of the abstract and the full text, we came to 46 studies that we looked at. And let's just roll right in. First, we want to look at the matched cohort studies. The matched cohorts are showing that if we look at the incidence rates, we see that there is even a lower incidence rate in the AFT group than in the control group. But this is statistically not significant. So we have this, these are the better studies, the matched cohorts, but not statistically significant difference. So that means in the end, both groups have sort of statistically the same incidence for local regional recurrence. And then if we look at the non-matched cohorts, then we see that there is a favor for AFT and that there is a statistically significant difference. But we have to see that these are not matched cohorts. These, the quality of the studies is not as good as before. So we have to keep that in mind. And if we look overall over all the studies, then we see that it's not really such a huge difference. We are somewhere in between, and we don't see really a difference between these studies. So as a conclusion, we can say that we have pooled data from 32 studies, more than 3,000 patients in it, and we have consistently no increased incidence of local recurrence rate after AFT. So just from this, from the studies we have, we can say that lipofilling is safe in breast cancer patients. But, and I know this but comes always, 2.5 years follow-up is short. So we have to look at these patients, and I can just ask the guys that did the big studies to look at their patients again after 5 years, after 10 years, because only this will convince everybody. If you can show that your patients are still living at 5 or 10 years and that their incidence rate is the same as the control group, then we know it for sure. You can even combine existing data across multiple institutions. That would be an ideal ICOPLAST project. Takes a lot of time, takes a lot of work, but if somebody would like be happy, I would be happy to join. Okay, let's move further and let's look at the efficacy. So it's not only, it's also important to see not only if it's safe, but also if it's effective. Do we really reach something with this? And we also did a meta-analysis there, which yielded in the end 89 papers that we looked at. And there we looked at patient and surgeon satisfaction. And if you look here, you can see it, we looked at oncological deformity, breast conserving, therapy deformity, whatever. And the more on the right side you are, the happier the patient or the surgeon is. And nearly everything is really, really far on the right. And here are the breast Q scores of the same with the domains of the breast Q. And we also saw that it's in the end, the median is 73, which is really good. So that seems also that people are actually happy with their outcome. And here we have the complications. So the more on the left side you are with one of these dots, the less complications you have. And except for a couple of small studies, we have really, really, really low complications. And if you look further into it, it depends on the study what you call a complication. It can be even a bruising, it can be a swelling. So it's really the rate of complications is really low. Then we looked also at the volume retention, because this is also a discussion point, and this is what we found in our meta-analysis from the data that we had. So in the end, it shows that after about 6 months, we are somewhere between 50 and 60%. We are also looking into this. I'm not quite sure if this diagram would still be the same, but this is what we had about 2-3 years ago. I'll think we're gonna update this again. So let me conclude the efficacy part. So we have pooled data from 1,700 patients, about 32 studies. We have a high patient and we have a high surgeon satisfaction. We have low rate of complications, about 50 to 60% volume retention after 3 months. So in the end, we do not only have a safe procedure, but we have also a very efficient procedure. Okay, and this led in the end to something that we have started a couple of years ago, which is called the breast trial. You can also find it online on thebreasttrial.com. Or yeah, I think so. Is a randomized controlled trial where we looked at nearly 200 patients which were randomized into 2 groups. One that were looking at lipofilling, total breast reconstruction with lipofilling, and the other group was with a procedure based on first an expander and afterwards a prosthesis for breast reconstruction. We looked at the oncological follow-up, and but the primary outcome measure was the quality of life 12 months postoperatively. This was a multi-center trial, so it were 6 hospitals that took place in this, and we spread them out over the whole Netherlands to achieve a good spreading so that everybody could find a center in the near. Here we're looking at the inclusion and exclusion criteria. We had female patients aged 18 years or older, and they had to have had a mastectomy in the past or planned and wanted to undergo a reconstruction. And we excluded smokers, drug abuse, allergy to lidocaine or silicone, and we had, and of course, a history of radiotherapy as well as diabetes, BMI above 30. This is maybe important for some. And we also said that we are gonna only reconstruct a cup size of C and not bigger. So that was also important. What we did is we looked at breast Q questionnaires for the quality of life and satisfaction with breast, with outcome, sexual well-being, physical well-being, psychosocial well-being. And we used the BRAVA or EVE cup and for expansion of the breast by negative pressure. The idea is that we get more space and more fat cells surviving, and of course, in the aftermath, an external splinting of the results. Furthermore, we used the Canfield Vectra 3D camera to assess the amount of volume that we had before and after the procedures. So we conducted this randomized control trial from November 2015, and the follow-up period closes this October. So we had a one-on-one stratified randomization, and we had dropout. So we had only, in the end, 86 per arm. What I'm going to show you now is our interim analysis, which was 128 patients, of which 61 were reconstructed with AFT and 67 with prosthesis. 14 were excluded because they did not finish the reconstruction. And we have, of course, still some missing follow-up at 6 and 12 months, which is due to COVID and therefore missed outpatient visits. And of course, because we're not fully at the finish line. So the intervention group went so on that we used AFT intraoperatively, which we did only in the first year and then stopped it. And then for the next sessions, we used the Brava 4 weeks pre-operatively and 2 weeks post-operatively. And about 4 sessions were needed to get a final breast mount. And the breast Q was done at inclusion 6 months and 12 months after reconstruction. So this is just an idea that to give you come from the left side really completely flat chested, and you get over the complete reconstructive period to a normal breast that looks just like the healthy side. And the control group was with the prosthesis, which was the standard of care at the moment when we started the trial. We started with placement of tissue expander, filling until desired volume, and changed to a prosthesis afterwards. And also the breast Q was conducted at inclusion 6 months and 12 months. So if we look at the baseline characteristics, we see that we have an even distribution. We have the median age, the BMI. I have to say we have a BMI median of 23. So don't you think that we get only people with BMI of 28 or so? And we have also a cup size of BC mostly. The wish for immediate reconstruction and tissue expander and the indications for why they joined the trial were everywhere the same. As I said, 4 sessions. We had a minimum of 2 sessions and a maximum of 7. And the average injected volume per session was nearly 200 cc's with a standard deviation of 50. Here are just some results. In the upper part, you see the before, and in the lower part, the after results. Here again, a results just after mastectomy, and in the lower part, the final results. Let us look at the quality of life. So if we look at prosthesis and AFT, we see that at inclusion and at 6 months, we don't see huge differences. But the real differences come at 12 months. There we get a satisfaction with breasts, the physical well-being, the sexual well-being, the satisfaction with the outcome everything was statistically significant, or at least clinically significant. And if you look at here at the same over time, it's maybe makes it more comprehensible to understand. You see that everything goes up, and that the pink bar, which is AFT, scores in the end at 12 months postoperatively nearly always better than the prosthesis. And we thought, okay, let us do a regression analysis and to see, is this really on the type of treatments? And if we look at this, we see that it is really the type of treatment that accounts for these results. The serious adverse events, so we have to look also at safety, and the safety was also the same in both groups. We had a breast cancer contralateral more in the AFT group, but we had a more radical resection in the oncological in the prosthesis group. But in the end, we didn't see any differences in the prosthesis or in the AFT group. So it was in total the same. Only the adverse events in the prosthesis group were more. What we saw in the adverse events was that the AFT group was more, 43 against 24, but of course, AFT had more operations. So pain at the liposuction site or in a small hematoma so was more common in the group that had more operations. So in the end, AFT and prosthesis are the same on the baseline. AFT scores higher in all domains, 3 of 5 significant and 4 or 5 clinically relevant. And it is dependent on the type of reconstruction that you get a higher quality of life. And in the end, AFT shows no difference compared to the prosthesis group. And in the AEs, AFT had more operations, therefore more adverse events. Limitations of this study until now is that we have a missing follow-up. We have a differential follow-up. We have also the COVID crisis that could also influence the mental health and therefore the breast queue. And we had, of course, more dropouts in the prosthesis group because people wanted to go into the lipofilling group and we couldn't get everybody what they wanted. So we're going to look further in the coming future and do an additional analysis on TNM status, the history of reconstruction, and a longer follow-up. My conclusion is quality of life is better 1 year after the reconstruction in patients that underwent AFT-based reconstruction. And there has been no evidence of oncological safety issues in the AFT group compared to the prosthesis group. And I, of course, have to thank you to the whole team that has made this possible, everybody that has worked hard in the Netherlands to make this possible. Thank you very much. Yeah, and now I'll give back to the host.
Thanks, Angie. Okay, you stop sharing. Thanks, everybody, again for joining. If you have questions, use the Q&A function. Just to start it all up, actually, we see people from Nepal, Taiwan, from Nigeria, Malaysia, Mexico, Palestinian, Iraq. So we're really connecting the world here. Angie, what can you tell us on because when we do these things in breast, there's two things: can you induce tumor? But another thing is, can you see the induced tumor? What is your thought on safety of radiological screening or oncological screening? Do you need to change the protocol, or do you need to do mammograms or ultrasounds, or what can you tell us about this?
Yeah, this is a very good question, but this is something that we don't know until now. We are conducting MRIs. We have beautiful discussions with the radiologists about this, because we would say, okay, the best thing is just to do a mammogram. If you also go for the healthy breast, just to put the reconstructed breast under the mammogram and you see if there is something growing. But they say, okay, we won't see anything because yeah, it's just fat. Okay, I get this as well. So if in doubt, I would just recommend to do an MRI, because this is something that they really can relate to. And what they mostly see is just fat. And we had, like, I know there was a case in Hengelo, and we had also a case that we had a recurrence. And what we saw is that the recurrence was in the pectoralis, but not in the reconstructed fats. So it's really strange, but it stays outside of what you put in there. So we don't see a spread out tumor somewhere growing or so. We saw in these two cases of recurrence only that it came back at the margin where it was erratically resected 1 or 2 or 3 years ago. And this is what we saw.
Roger is suffering from some jet lag, but Roger, what is your thought on follow-up after lipofilling in terms of being used MRI, or can you see recurrences? What are your thoughts on this?
When I started doing lipofilling of the breast some 18 years ago, it was heresy. And so in excess of safety, I required an MRI baseline of every patient and a 6-month follow-up in every patient that did that surgery. And I realized it's really a very, very good tool. So at this point, I still require a baseline MRI every time I do lipofilling, whether it's, I mean, unless they've had total mastectomy, there's no breast tissue remaining. But if there's lumpectomy or an implant or a cosmetic, I require a baseline MRI. And sometimes you find things that you don't want to find, and that you send them to some to biopsies. But I also make sure that they come back and get a 6-month follow-up MRI. The follow-up MRI is very important. And I tell them, we change the architecture of your tissues. You need to have a new baseline for the rest of your life, something they could refer to. And it's also important to really see what you put inside this breast. Make sure that what you have inside this breast is really live fat and not necrotic cyst.
Okay. Alias Najafian, hello from Portland, Oregon. Great talk. I can only echo that. A question, Angie, on average, how many sessions of grafting do you do, and how often do you do those?
Yeah. The typical timing between sessions is about 4 months. We came about that this works well. We try not to get it shorter between the sessions. You can do longer, that's not a problem, but shorter than 4 months is a bit of a thing. And we need about 4 sessions. We see now that with the learning curve that we had in this trial, that the amount of sessions goes down. So I think we are now below 4 sessions. But I think if you start, you should really tell the patient that you need 4 sessions. I think this is okay.
There's a question from Professor Menke. He's asking about low grading of the tumor is not a contraindication for lipofitting of the breast, or do you recommend these patients a certain interval? I would pose the question wider. Is there any role of type of tumor or stage in deciding yes or no to do lipofilling? And let's do a lumpectomy breast.
No, I think there are 2 parts to this question, because it's a different thing to completely reconstruct the breast, because we have really focused just on the breasts that went for amputation but did not need any radiation therapy. So then we are starting off in the idea that it's oncologically safe, that the surgeon has completely cut out the tumor with good margins, and that we don't need any radiation to get oncologically safe. I think it's a different thing if you go into lumpectomy defects. This is a whole different ballgame. I won't go so far to say you can do it everywhere, because I don't really feel anywhere where you can be safe. So I won't give you any recommendation on that. Sorry.
Thanks. That's good to know too. There's a couple of people, Fatma Elzara and Jose Martinez, that ask how much fat do you inject per session, but I'm sure Roger will get back to that on his talk. As well as, what techniques are better or worse, and how much evidence is it for the one technique over the other. A final question then from Mrs. or Dr. or Mr. Aganlu, dear Professor Piatkowski. Do you have any explanation of the seroma rate as a complication in the AFT group? Was the seroma in the donor or graft site? Did you see a lot of seromas?
No, it was pretty low. And that was actually always the donor side, what we saw it in. And I wouldn't even know exactly if there was a preferable site or so, but that was always the case. But there was nothing that we had to operate on. It was just a longer time that you had fluid coming out. But there's nothing that was a severe adverse event. So you didn't need any intervention.
Okay, well, Tariq Ahmed also asks questions about what body habitus is the ideal candidate, and a lot of questions that I'm sure Roger is going to dive into right now. So let's leave the discussion here for a minute. I will get back after Roger's talk. So Roger, if you want to start sharing your presentation, and we're looking forward to hear from you. Are you still muted? Roger is getting his things up. Maybe Angie, so we're now, I think the people that have joined can't see this, but we're about 500 people. So we got a great crowd. And again, I think we're over 40 countries or so. So that's good. So Roger's ready to rumble. Are you muted or did you unmute? I'll mute now.
Well,
Thanks, Roger.
hello, friends and colleagues across the world. It's a different world, isn't it? But thank you all for attending, and thank you, Hinne here, and the team in Holland for inviting me and making me part of this. This is a great show, but it's really humbling to speak after Andrzej, who's done some great science. I'm just a pioneer, but he's the one who's doing the real science there behind this. I'm going to talk to you about the fundamental principles, because the most important thing is the principles. You can't go anywhere without the principles. And having done this for nearly 20 years now, I can tell you it's all about the fundamental principles. If I can get this next slide here. So my former life, I'm a microsurgeon, and Bob Ackland was my role model. And one of his quotes here is, a bad surgeon blames his tool, but a better surgeon fixes them. And as you know, Bob developed a lot of the tools of basic microsurgery. So following his teaching, I realized that fat grafting required new tools and new thinking. And along the way, that's what I did. One of my travels before COVID, I met a plastic surgeon who was very proud of his results, even shared his slides with me. He said, Roger, I do beautiful breast augmentation with fat grafting. I have a 60 cc syringe and I inject it in a deep compartment here. And he's so proud to show me his MRIs there. And he said, look at the fat in there. Well, this is a necrotic oil cyst. This is not my operation. This gentleman is repeating history that has failed and has led this operation to be banned by the societies. This is going to be a problem in the future. This patient may look and feel good initially, but it's going to be rock hard and calcified and painful, and going to require excision. So this is not what we're talking about. First, the fundamentals. Michael Jordan, the basketball legend, so you can't, if you don't have the fundamentals, first fundamental. And the fundamental rule number one is blood flow. We're doing avascular grafts. Avascular graft will not survive without blood flow. You need revascularization. And revascularization depends on the graft-recipient interface. And that's been well proven through multiple models, 1 to 1.5 millimeter maximum. That is, no adipocyte should be more than 1.5 millimeters or so away from a capillary blood supply. You need to have a healthy bed for sprouting. Yoshimura has done some beautiful science to see that, and he showed the 3 zones of survival. The most peripheral zone survives naturally, but then you have a zone in between, that regenerative zone there, where only the stem cells that are more resistant to ischemia survive. But then beyond that 1 to 2 millimeter, everything dies. So you only have a shell about a few millimeters thick that survives. Since we deliver ribbons, you have to deliver ribbons that are only 3 millimeter wide. A ribbon wider than 3 millimeter would invariably have necrosis. Matter of fact, 1 ml droplets will have 40% necrosis, because only the periphery, the shell, would survive and everything inside will die. So if you think about, we inject with a syringe and a cannula. If you inject without moving your cannula, just press on the you're going to deliver a blob, regardless of the size of your cannula. Even the thinnest cannula, if you inject without moving, it's going to make a blob. If you inject while retracting a long distance, it's going to be a thinner ribbon. So the math there is very straightforward. It's simple geometry. A 3 millimeter base is a 10 millimeter square base here. To deliver 1 millimeter cube, 1 ml, which is 1,000 millimeter cube, on a cylinder 10 millimeter square, you have to retract 100 millimeter. Therefore, the fundamental rule of fat grafting is never inject more than 1 ml per 10 centimeter of cannula retraction. Now, Sid Coleman realized that intuitively when he started doing that with the tuberculin syringe, and it took him hours to deliver a few hundred cc's, and because he was delivering tiny micro grafting. So the concept here, and it's all has to do, it has nothing to do with the size of the cannula. You see, this is a thin cannula, a thicker cannula, twice the size. If you on graduated paper, and if you want to deliver a 3 millimeter thick ribbon, you have to move this is a toothpaste. You have to move your syringe for 10 centimeter. And notice there's a lot of precision there, because if you move a little more while delivering less, it's a thinner, it's going to be thicker here. So there's a lot of precision there. And the precision has to do with how precise you are with your thumb as you move your cannula through the tissues. Now that has to do then with the size of the syringe, because a 60 ml syringe, 1 centimeter, which is, precision of a plunger there, is 6 ml, which means 60 centimeters. A 10 ml syringe is still 20 centimeters, significant advancement, which is not precise enough. A good compromise is a 3 ml syringe, which is 0.4 ml, which is about 4 centimeters. So you could do that. And so 1 centimeter, 0.4 ml is pretty feasible. So the greater syringe, the greater precision. So the fundamental rule of fat grafting, do not inject without moving. I see people who do this and then they inject. They do this and they inject. No, they inject a blob. And the injection motion rate is ml per centimeter, not ml per second. It's ml per centimeter. It has nothing to do with the size of the cannula. It's the size of the syringe. And don't go back in the same direction. You see people back and forth in the same channel. No. So you have to really optimize this interface. Now, the way I do it, of course, is to save time, is instead of spending my time switching syringes and cannula, I use a valve out of a bag, and you just re-aspirate in a single-handed movement there. And I have a long cannula and a 2 cc syringe, 3 cc syringe, and I inject as I retract. Now, so my most common operation is fat grafting to replace an implant. There, I put my finger inside the cavity to control the cannula there. And again, that allows you single-handed grafting, because I don't have to have a free hand to connect and disconnect and reconnect. Speed in surgery is not fast movement, but economy of motion. It's all about economy of motion. Now, second principle is the recipient capacity. Just like a skin graft, a wound, you can't graft more than the size of your defect. In 3D, you can't graft more than what your defect can expand to accommodate, even if you're very good at squeezing those without coalescence, etc. There's a point where the compliance is such that the tissues are choked. Now, our subcutaneous tissue, normal healthy subcutaneous tissue, is the healthiest tissue, and it can expand to 50% without really reaching that pressure that would choke it. Beyond that, the slope is straight up, which means a small percentage change, not the volume absolute, it's a percentage, a small percentage change goes straight up. Now, some non-compliant tissue, of course, is much less than that. So you really have to look at the compliance of the tissue. One way to look at that is yellow balls into red balls, and you can't put more yellow than red. If every yellow is going to be surrounded by red, you just cannot put more yellow than red. So here's an example. I put 11 balls into a 42 ball recipient, and I get a nice 53 construct, no coalescence, every yellow is surrounded by reds. But then Andrzej tells me, doctor, she needs a little more here, right there. And that's typically the scar. That's the worst part. But that's where I want the most projection. She needs a little more here. So, okay, I'll put 10 more balls here. And now we have screwed it all up, because now we overfill the container. Now we have coalescence. We have increased pressure. Now the whole thing is going to destroy. I wish I stopped here and came back another day. And that's the problem. Less is more. Now, one way to look at it here is you can, if you tease your balls inside, you can get excellent survival. Survival can be perfect, but you haven't increased this volume until you really filled it up. Once you fill that recipient, the more you graft, the worse it gets. The more you graft, the worse it gets. So this is the percentage survival curve. Now, if we look at the percentage augmentation, which is what matters by how much you enlarge the tissue, initially you haven't augmented much, but then until you fill it up, once you reach the maximal capacity, beyond that again, it starts dropping. The more you graft, the worse it gets. So they're two separate curves, and they're very important to realize the difference between percentage survival and percentage augmentation. Everybody's concerned about percentage survival. It has no relevance, because here, when I grafted a very small amount and I teased it nicely, I can have excellent perfect survival. I haven't augmented the tissue by anything. So, you put 10 cc's or 100 cc's on a 1,000 cc buttock, yeah, 100% survival, but what your graft increased by 10%. Whereas what really matters is, since the goal is to enlarge the tissue, the measure of success should be by how much you enlarge that tissue. So I really urge you to really use percentage augmentation of the tissue as more important. Another way of looking at that is it's a stoichiometry to be respected, a graft, a recipient, surviving graft recipient complex. So if you have 12 grafts and 9 recipients, and you're very good at dispersing them, at best you're going to get 9 surviving graft recipient complex, which is 67% survival, right? Now you still have 12 grafts, 6 recipients. You're very good at dispersing, you get 50% survival. You have 12 grafts, 4 recipients, 33% survival. What's survival to do? How much of a brute or how timid you are? So you have 12 graft, 3 recipient, 25% survival. And that is if you're very good at making sure every graft finds its recipient, which is not the case all the time. So percentage survival is really a measure of over-under grafting. Please abandon it. The most important thing is percentage augmentation, since the goal is to augment the tissue. So that's what I plead to all my colleagues and everybody who writes paper, and every time I review a paper, say, guys, I don't care what your percentage survival. First of all, I don't even know what your numerator is. I don't know how concentrated your fat and how dilute your fat is. So that is irrelevant to start with, because we don't count the number of cells. So you don't know what you're starting with. So really what matters is so the only way to enlarge the tissues beyond just stuffing one reagent, which is going to give you nowhere, is to increase of the other reagents. So you have to match the stoichiometry to, and fat is not a tissue expander. So if you really want to have more tissue, you have to expand and create more fat. Now, the third principle is the recipient matrix. You always have to think of our soft tissues being held together by a scaffold, a fibrovascular scaffold. Some of it is delicate, healthy capillaries, and some of it is scar and fibrous tissue, but you have to respect it. That's what gives our tissue shape. If you go in there and you can take a block of scar, you can mesh it in 3D and turn that scar into a recipient scaffold. I call this cicatrix to matrix. But if you go there and you destroy it by large cuts, you create cavities, and cavities the enemy. So you got to go there and loosen a scar into a recipient scaffold, not into a cavity. One way to do this is the jackhammer grafting. This is not accelerated. This is actually the speed. And I'm loosening the scar here in the tuberous breast, which is a congenital scar. And we're loosening it with a blunt cannula to go there back and forth. And that's how Sid and Gino really started and taught me how to do it, by loosening that scar with a blunt cannula to loosen that fibrous scaffold. And every pass you deliver a droplet of fat to expand it to grow back. Now, I was part of a panel of these societies to look at fat grafting the buttock. We invited plastic surgeons from all over the world, experts in buttock fat grafting, and then we gave them a colored liposuction fat, and we had cadaver buttocks specimen, and we told them to operate the best they could. We gave each one of them 1 liter of fat, lipo, and to do their technique. So the guy here came in with a 60 cc syringe, and in 10 minutes, he put the fat. You notice when we cut, there was some area where the fat leaked and some area that was ungrafted. This guy here, took him an hour. Poor guy had a bunch of small syringes, and he went 1 droplet at a time, delivering it, making sure every place is, and look how much even his fat is. Now, which one you think will have a better fat will take? How much will really survive eventually? Obviously, the guy who took his time delivering tiny droplets. But then we had the cowboys who went with reverse liposuction with a pump and then delivered 500 ml a minute, which you followed the rule of 1 ml, 10 centimeter. They had to 5 kilometers on that ass in a minute to just. And then once we cut the fat, look what they did. They destroyed the scaffold. They basically created a cavity. It was all destroyed. So one way to look at fat grafting, and finally the fourth is the realization that it's a chain-linked reaction. A lot of things we do in surgery are chain-linked in series, and the outcome depends on the weakest link. In microsurgery, for instance, it's not only the anastomosis. You can have a free flap because of a kink of the pedicle, of a tight dressing, or a patient wrapping. A million things can cause a fade. And the weakest link will cause, you have excellent anastomosis, yes, you get a fade or free flap. So one way to look at fat grafting is you have the seeds, the soil, the sowing technique, and the support. Everybody talks about the seeds, how you add to them, what you do, how you prepare them, how you stem cells, etc. All kind of magic thing they want to go into the seeds. But they don't realize the best seeds in the world put in a little rocky pot will give you nothing. And if those seeds are going to grow, thank you very much. I want nothing that grows in the breast. So you really have to have good seeds in a large enough field, well fertilized, well prepared. And then like the good farmer, you're going to go one seed at a time planting them. If you have the best seeds in the best soil, you put it only one corner, you've done nothing either. So it's a seed, it's the soil, it's the good farmer who craftsmanship delivers one at a time. And if you've done all of these and you allow it to dry, you stamp it, you shake it, etc. Again, the same thing does work. Every time we do a graft, whatever graft we do, immobilize it. Why not immobilize our fat? Why is fat not to be immobilized after you graft it? So each one of these can be rate limiting. One way to look at it is a chain length, and the weakest link is going to cause the failure here. And typically for large volume fat grafting, it's not the amount of fat, it's the recipient, the small recipient that can accept this large volume that's going to be the problem. Of course, the surgeon that grafts also the technique has to do. So one way to look at it is a car racing analogy. There's no point in having 500 horsepower if you're stuck in traffic. And so stem cells work fantastic in the lab, but there's not a single study that showed stem cell improve tissue augmentation because it's adding horsepower to a car stuck in traffic. A moped can be the car stuck in traffic. It's having a 5-lane highway that ends up in a small bridge, one car at a time. Enlarge the bridge, don't point. I don't care, but you could have 10-lane highway on the other side. The limiting factor is going to be that one car at a time passing that bridge. So it is really important to look at the whole thing and focus on the rate limiting step. It's counterproductive to invest into non-rate limiting steps. And so, and everybody looks at the miracle additives, whether it's wound healing, whether it's immune compression, whether it's everything. The philosopher's stone from the alchemist days till today still wants to have something that's going to make it work. And there's nothing that replaces technique and fundamental principles. So to recapitulate, there are 4 factors here. The fundamental one is blood flow. For this, you have good recipient interface. And for this, you need to have a fine syringe that carefully delivers that graft. 2, you have to respect the recipient capacity. You cannot overgraft. If you overgraft, you're in trouble because you've killed it. 3, respect the scaffold of that recipient. That's what gives it shape. That's what you can loosen, but don't destroy it. And finally, realize that there's a rate limiting step effect like everything else in surgery. And there's no point in having fantastic stuff there. You sterilize your hands, but then you put shit later. Yeah, but my hands were sterile, but you put shit later. So, there's another factor down the line that can screw up the whole process. So, and again, never overgraft. My complications have come mostly from trying to do my best and go beyond this. Doctor, please make sure this is my last operation. Okay, I'm just going to graft a little more, and then I wish I never did it. And so which comes to most difficult questions, knowing when to stop, how much to graft every time. And that is probably the most difficult question because I don't have a good answer. I have no good answer. So this one way to look at it is the palm and pinch. My palm is 200 centimeters squared, 10 by 20. And that gives me an idea of the recipient's surface area. And I can pinch it and I get an idea of its laxity and thickness. And I can never graft more than the volume of my recipient. That's the upper limit of dilute fat, by the way. I'll talk about that later. Now, another way of looking at it also is the expansor volume. If you've expanded externally, that's bonus volume you can fill in. And obviously, you know to know when the tissue is full. And a peau d'orange is a very strong tightness. You don't want there. The reason I like dilute fat because it gives me a margin of safety. There, if I've overfilled it, overfilled with fluid, not with concentrated fat. When we look at the expansion volume ratio to final augmentation volume, we found it's at 3:2. That is, what we found is that if the patient triples her volume with external expansion, she'll end up doubling her volume in the final results. So the limiting factor is really the large recipient soil And this is how I got into fat grafting, and really showed that if you stretch it from the outside, this is an MRI before and after external vacuum expansion, you could see how much more vascular, how much larger it is. So this is tissue engineering in vivo. By just putting an expander there, a suction, you create a scaffold, it's tissue envelope that you can seed with cells and regenerates. And it's just, obviously you can see this involutional atrophy of the breast. You can get tremendous augmentation in just 2 weeks, 15 days of expansion to get a beautiful augmentation. And typically if they triple, they'll double. These are simple cosmetic augmentation. And that's the way I do my augmentation today. If I triple, I double it. So let me talk about the techniques now that adhere to those principles. First, the grafting. No patient is too thin in my operation. I have probably been doing this since 20 years. I probably turned out 2 or 3 patients my entire career, and these were anorectic patients that were on tube feeding and had already liposuction a few times. I mean, otherwise, everybody has enough fat. My palm is 200 centimeters square. If I take 2.5 millimeters, that's already 50 cc's. The trick is how to harvest a thin layer out of a wide surface. For this, I like to have a fine cannula that allows me multiple needle stick entry. I don't use a scalpel, don't suture. And because of multiple entry side, you can crisscross harvest and harvest thin area of a wide surface. Now, I started doing it with regular original cannula of Coleman, which was a bucket handle, 1 hole. And I realized, wait a minute, why don't we put more holes? So we did a study a while ago and showed that a 12-hole cannula at 1/3 atmosphere was more efficient harvesting than a 1-hole cannula at full 1 atmosphere negative pressure. So obviously you want to be lower atmosphere. So it's better to have 12 holes. Of course, 15 holes even better, but then the cannula has all holes, there's no working distance. So my preferred cannula here is 3 millimeter in diameter. It's a long one, which allows me long passes. It's got small apertures, which allows me to get a small, fine granular fat. It's got low winglets that creates low trauma to the capillaries, harvest more stem cells, and I can enter through small needle stick all around the patients, all around the entry site. This is how I used to do it with a constant pressure syringe, which just simply sucks it up. It maintains a constant pressure as you do it here, and as the fat fills up, you squirt it into a bag. The alternative technique is what we've done here today, which is when you have an assistant who can actually man the pump there, and you just basically do it, and the assistant, whenever it fills up and the bag fills up. Once the bag is full, it actually fills up very rapidly. My preferred donor site is the posterior flanks, and we put the patient prone, and we typically harvest it in a 2-team fashion. And you can see how it fills up pretty rapidly. Those bags are 200 cc bags at the lipografter system there. And we, once the bag is full, all we got to do is simply hang it on an IV pole there with those stands there. And it separates very nicely. I like the super tumescent. You really want to put plenty of tumescent fluid, epinephrine there, so that you get a very clear aspirate that separates very easily. If it's bloody, it won't separate as well. There's a gradient of fat that happens there. This is more yellow. First of all, there's no oil. We don't destroy adipocytes. There's no bubbling of air. And notice that whitish layer. These are the best one. It's proven there by a lot of studies. Sid Coleman has shown these are the heavier adipocytes, the one that take a longer time to come up, the whitish one. These are the finest one, and they take a long time to come up because they're denser and they don't come very rapidly. And that fine dust goes away if you filter or if you wash it. So this is a centrifuge fat. This is the fat that comes out of the simple sedimentation. This fat is better because this fat will percolate through the tissues and improve graft-recipient interface. People say, doctor, I don't like it. I want fat with consistency. Well, bullshit, you're not putting a filler here. You want something that percolates and mates with the tissue and mates with the tissues. So you want this dilute fat here. It's got margin of safety because of glass fluid. It better contact, better dispersion. It flows better through the cannulas. It puts the fibers under tension with the excess fluid. And basically you can preserve all the goodies. So this is the PAL machine connected to the wall suction. Now, the PAL machine is a very efficient machine, no question about it. But look at the bubbling here that happens there. That bubbling here kills the fat. And the proof is simply there. Here's a fat harvested with a close, low pressure, low airflow system. And here's the fat harvested with that machine there. You see how it's oily? It doesn't separate as well because we've killed those adipocytes. We've just basically, with the bubbling there, it's altered. So how to prepare the fat? Centrifugation is a standard. It came down to the mountain from the mountain to Sid Coleman, and that's how he preached it as the standard Coleman technique. But it's really clumpy. It is cumbersome. It damages the fat. 1200 G. If you put a human being at 1200 G, it's a monolayer. You destroy him. It's flat on the table. I mean, imagine what you want to put yourself through 1200 G. I mean, so it really crushes everything except what cannot be crushed anymore. Filtration, you lose the best parts. You saw that. The best one that really could not understand is the washing. Why? Is it dirty? Oh, we want to take the blood out. Well, there's no blood, or you put it back in. Oh, I want to take the platelet plasma, the platelets. Wait a minute. Most people want to put it back. They add PRP in the fat. What are you doing it for? So sedimentation is the most practical. Keeps all the goodies. It gives you loose recipient. I like Teflon rolling. It's good for the hand. I use Teflon rolling, but it's not practical. And of course, everybody is looking for the magical, the philosopher's stones, the supplementation. There's not a single study that shows that any supplement makes a difference except in the rats in the lab. And rats have no relevance to humans in this situation. So let's about the graft phase. Again, we agree no blood flow, no survival. It has to be with angiogenesis. You have to deliver the ribbon with a fine cannula and respect the 1 ml, 10 centimeter rule. And you have to fan it all over. So I go through multiple entry sites and I sprinkle the fat layer by layer, thinking superficial, low, deeper, through the gland, subglandular, all over this. And it's evenness to randomness. And it takes time and craftsmanship, and you have to loosen up the tissue as you go. I like to use curved cannulas because the contour of the body is curved. And I like to have blunt tip, which allows me to bluntly dissect it. I like a long one for long strokes and a short one for smaller passes. I like to use a valve again, because that way I don't have to switch it, unswitch cannula. And here's how the setup I have. The fat comes from a bag, through the valve, through a 3cc syringe, a curved cannula. And I typically put the patient sitting up a little bit. I put a face clock markings all over the breast, and I go all around it and plan to disperse the fat in every layer, one layer at a time. Here I'm going in a deep layer from above to below. And as you can see, I basically graft as I retract, reload, graft as I retract, reload, graft as I retract. The ideal situation for fat grafting is the median mastectomy. There you have an exposed muscle, which has no fascia, and you can deliver tiny ribbons of fat into the flaps. If the flaps are thick enough, you control this under direct vision. And the beauty is the exposed muscle there, you can just tease it, and under direct vision, tease those fibers and fill them up so that you can pull quite a bit of fat, and the patient wakes up with a significant fullness. This is my very good friend and really probably the world's expert in doing this. He's the one who's got the world's largest experience, Gino Rigotti, and this is how he does it now. I was with him just before COVID. He basically, this is a syringe that you use for liposuction. He aspirates it with a stock cock. He goes to a 3cc syringe and hands it to, and he injects it. Now, obviously, the economy of motion there is terrible there, but the lipografter was not a CE mark approved, so he doesn't have to do it. Whereas if you do it directly with a syringe and a cannula, if you think about it, if you use 10 seconds cannulating and decannulating for 300 cc's or with 3cc cannula, it's 100 seconds, and it's basically an hour OR time. Now, post-graft care, you never do a graft without immobilizing. Why not fat? So Gino and I developed this splint that we apply on the patient to hold it in place. And what it does, it prevents the swollen tissue from recoiling, maintain a constant tension there. So recap: the seeds, the soil, the sowing, the support. First, master the fundamental: blood flow, match graft amount with the capacity of the recipient, and percentage survives is a fallacy. Fat is not expanded to survive. You have to pre-expand, create more space, loosen, reshape. Chain link factor, there's no magic, no wonder grafts. So basically, I have plenty of myth and fallacies like additives, non-approving adequately, stem cells. It's horsepower to a car stuck in traffic. 500 horsepower won't help you if the traffic is bad. Graft retention is irrelevant. Another one is weight gain before surgery. The opposite, man. Try to lose weight before surgery. I want you to gain it after surgery, not before surgery. And not enough fat, that's not true. Not everybody has enough fat because we're harvesting a thin layer out of a wide surface area. And the cannula size determines the ribbon size. No, it's a syringe that determines the ribbon size. I like a thin cannula because it allows me to enter through multiple needle sticks without a scar, but that's not because it's going to give me finer ribbons. And the contour defects are not just volume deficit, they're tethering scars. There's a three-dimensional scaffold that you have to loosen up. So in conclusion, success depends on chain-linked factors in series, and the weakest link will determine the outcome. So always think of what is the weakest link, and that's what you got to focus on. The weakest link in Vega volume is often the recipient capacity. You have to determine the recipient capacity prior to lipo harvest to have an idea how much you're going to put in there. Okay, always deliver never more than 1 ml per 10 centimeter ribbon as you graft. Precise sprinkle delivery. It requires craftsmanship and time. Respect that route to the scaffold. Do not destroy it, but loosen it up to allow it to expand. Preserve the swelling of post-operative splinting. And finally, mega volume fat grafting should not measure percentage survival, but more relevant percentage augmentation. And if we look at the literature, it's never more than 40, 50%. The guys who give me their raw data, I went there and calculated it. They really, you cannot enlarge it more than 50% at best, unless you pre-expand. There's two ways to pre-expand, either external expansion or downsizing an implant, which is the topic for another presentation. Again, you're all welcome to come in Miami and see this in your own eyes. Tom Biggs, my mentor on this here, has been with me for a long time and helping me with these courses. And thank you for your attention.
Wow, that's some really intense quiet after this course of presenting. Yeah, I am muted. Should be okay, I think. Yep. Okay. So maybe you can stop sharing.
I don't know. What do I?
Stop
sharing. Okay. Okay.
Everybody can ask questions using the Q&A function. Just to start off, there's a lot of debate. Roger and Peter Rubin and the ASPS actually has a committee on it on safety of large volume lipofilling. What are your thoughts when we inject, when you look at sites in the breast? What are your thoughts about high volume lipofilling in the muscles such as pectoralis, and what do you think is the difference between the cases of death and mortality in these, they call it Brazilian butt lifts?
Totally different animal, totally different animal. Okay, the anatomy is different. Let's talk about the anatomy first. The gluteal veins, and having done free flap there, I've operated and dissected them. They're the size of your thumb. It's a spider web, and it has a consistency of wet toilet paper. And it's very easy for these to bust. They're huge, okay? And they have negative, and they're under negative pressure too. So you bust them. You are nowhere near this kind of anatomy, the pectoral vein. The pectoral vein are in the millimeter, fraction of a millimeter range. So number one, different anatomy. Number two, those guys inject with a 60 cc syringe. I inject with a 3 cc syringe. I never deliver more than a fraction of an ml per pass. Those guys inject 50 cc per pass. They inject a liter and a half. I inject 200-300 cc's. So it's a total different animal. They don't care about survival. As a matter of fact, the honest ones among them will tell you 90% of our result is the liposuction around, not what we inject long term.
Angie, do you have any thoughts on this topic? Because obviously, if there's no breast mount and this muscle is looking at you, this is the ideal ground, and it's got the perfect soil to do the seeds if you sort of adhere to Roger's thoughts. If you unmute, but so we're looking at large volume injections like the Brazilian butt lifts, there's a debate on the safety of injecting in muscles. What do you think is what are your thoughts on lipofilling of the pectoralis muscle? Is it safe, or do we need to do
I think it is safe because we did it in the beginning of the trial, and it's not really a problem. It gives you a really, really nice upper pole, because the pectoralis sits only until the height of the nipple. And it really gives the patient initially a social breast. So they wake up after the first session just right after the amputation, and they wake up and they have still the beginning of a breast mount. We don't see any safety issues with that. This is another thing. It's only that the volume that you place there then moves. So you have a moving part of the breast. So you have to cover it afterwards with another fat layer in order that it doesn't move that much. We stopped it because we looked really at the amount of sessions that we had to do. We wanted to keep the amount of sessions as low as possible, so that thereby we stopped, because we thought it's not such a big deal to augment the upper pole. Because the most thing sits in the lower pole, and but you can do it. I think it's absolutely safe to inject the pectoralis. Yeah.
Just another question on the side from Ahmed Maged Mufti, and maybe to the both of you. There's always a debate on where to inject. Of course, we discussed the muscle, but when we looked at the whole oncological discussions, where Angie, you've shown that this is safe, but if there is a breast gland inside you, do you inject, what are your sites? Subcutaneous, intraglandular, subglandular, and we already discussed the pectoralis. Roger, where do you inject?
So first, I randomly
You need to unmute. Sorry. It's a chimeric meeting, so to speak.
Yeah. So first of all, for cosmetic augmentation, I assume you're asking cosmetic augmentation. There are three ways to do cosmetic augmentation. One is to do small sessions, realizing that the recipient is limited because you don't prepare it, you don't want to prepare it, and you want to be honest, and you tell ma'am, it's going to take you at least 2, maybe 3 sessions to give you a significant augmentation. One session without preparation, you're not going to get enough in there. Now, and it's all about percentage, of course. A girl who already has a nice C cup, you can give her 100 cc's, but it's not enlarged significantly. A girl who is a AA, you can't give her 100 cc's. And whatever you do, there's no way you can give her 100 cc. So it's a percentage augmentation. So you can do in stages. I don't do it in stages because it's pain. I just want to be done. So then you have 2 ways of doing it. Either you externally expand and there you graft everywhere, or you downsize an implant. My friend Yoshimura in Japan does it routinely now. He puts an implant in the ladies. Ma'am, you're going to get an implant for a few months. You like it or not, I'm going to put a scar, put an implant in there. And then he wears the implant. Then he takes the implant out. Now he has laxity. He has room by downsizing, because the difference in volume between a cupula of tissue around an implant versus a disc, same thickness, same base, is laxity can fill with fat. So then we talk about the 3 ways of doing it. Now, once you decide what to do, you want to graft in every plane, and in a very methodical way. The best grafting plane is a subcutaneous, because golf balls under the sheet give me more protection than golf balls under the mattress. So you want to graft subcutaneously, and that's my favorite plane. And if I've expanded with Eve, that's what stretches the most. That plane, I look at it at least 2 layers. Every layer is going to be 3-4 millimeters thick, and I can go through multiple sites and fill that up. Then you do not want to miss the glandular plane. There's no reason not to put in the gland. As a matter of fact, you want to open up the gland, especially in the constricted breast. And there you got to go very with the jackhammer technique to loosen up the gland, especially in a premenopausal lady with fibrous breast. You need to loosen up. You can't put too much. Then you go to the muscular plane. Muscle is a great recipient, but muscle with the fascia, you can't expand it too much and they start destroying that fascia. So then you can't say which is subglandular, intramuscular, or submuscular. To me, it's one deep plane. And I go there and I fill that plane. So conceptually, I have basically 2 preglandular plane, 1 glandular plane, and 1 deep plane. So I have 5 planes, 4 or 5 planes that I go in a methodical way through multiple entry sites and fill them up as much as possible, realizing that at least half the volume is, if half or 1/3 of the volume is preglandular, another half or 1/3 is submuscular, subglandular, and intramuscular.
Thanks. And that's also the question of Modeo. Question that we also keep getting is how long should you wait until you say this is the final volume? Isat is asking that. Angie, you go first, or what are your thoughts on this?
Sorry, I really don't know theory. Could you repeat the question? So we are injecting this volume. We're telling them about 50% will survive, or in terms of volume, referring to Roger's comment. When is the result? When can you say after so many weeks or months is it? Do you reach that point?
Yeah, when we look at our data, we think that it's about 6 weeks after the last operation, you know what you're getting. We see that there is still some reduction in volume over the next half year, but it's only a couple of percent. So it's pretty much 6 to 8 weeks after the last lipofilling, you know what you get. And the interesting thing is that it's mostly, which at least that's what we saw, is what you lose the most is between week 3 or 4 and week 6, 7. This is when really the grafted tissue that did not survive just is gone.
It's typically 6 months. But again, it also depends on the quality of the fat and what you've done to it. So in my experience, I try to maintain the postoperative volume for 2 months with the splints. So what you see right after surgery, I force it to stay there for 2 months with the splint that we put on them. So right there, you don't lose much there, and we force that void, that chronic edema, to turn into fat, that adipogenic chronic edema. But so the guy who put this big necrotic oil cyst, he's not going to see much loss for a while, except they're going to have a rock hard breast. So it's hard to say. Those of us who are careful and deliver micro droplets, we're going to see much early, and then at 6 months it's going to be stable. But the guy who delivers a big necrotic oil cyst, that's going to stay a while until she got surgery to remove it.
Thanks. A couple of questions on harvesting techniques. I mean, of course, every producer is going to say his or her product is best, but what is the evidence, or how do you think we can reach evidence in terms of what is the best device to use? Somebody's asking Mohan Rangashvini about, is phaser treated fat good, or what systems? How are we going to get to evidence-based tools?
I think there's evidence to show that. I mute myself. I think there's evidence to show that you want to be the least traumatic possible. Okay, despite this recent trend about nanofat and destroying fat, let's talk about that a little later right now, because nanofat is basically no fat. Okay, nanofat is no fat. You destroy the fat, you just have the stem cells. But that's not what we're talking about here. The idea here is you want to be the least traumatic. So it's well recognized the lowest pressure is better. Okay, so why do ultrasound when you know it's going to destroy it? You're sonicating it. So I mean, I don't see the reason. You could try, if you want to do it, do it. It's not the rate limiting step. The point is, it's been well proven through multiple studies that whatever technique you use makes no difference, because it is not a rate limiting step. So yeah, if you like to use Vaser or Baver or whatever, use whatever you want. But I like to use a closed system, which is not only low pressure, but also low airflow. I don't like to see that fat bubbling in the system there. And I like to use a cannula that gives me tiny, fine droplets of fat, because big globules won't survive. So I like to have a cannula with multiple holes, so that's efficient, and that has small holes that gives small droplets of fat, that is small needle entry side that allows me to harvest a thin layer out of wide surface. It's again, fundamental principles. Now you could use the PAL as a nice trick, but if you see, we can connect it to the I connect the PAL actually to the low pressure suction system, But then you also have to have a cannula with the PAL that not has big holes, because we did that today. We showed that the big holes of the cannula of the PAL gives me globules of fat. You could compare grossly. The fat of the PAL was basically granular as compared to the fine powder of the small needles.
Angie, do you have any comments?
Yeah, I have to say that what Roger says is absolutely true. We see this, and it's also what my experience is when we use a bigger cannula, and we use that for a long time. So I have to say we didn't listen. That then you get more granular fat, and you get into these problems that you have problems delivering the fat, and it's for sure better to get small amounts of fat in or smaller parts of fat, finer particles, because then you can deliver it more evenly. And what we saw today, really, with this low vacuum system, it was really nice. Yeah, so not always. But I think the key here is also to do it super wet for the liposuction, because if you don't infiltrate a lot more, I thought I infiltrate a lot, but I was childish. You have to infiltrate. If you think 1 liter is enough, okay, do 2 liters. It's even if you think everything is going to burst, it will be very good.
There is no downside. There is no downside to supertumescence. Really, there's none. And actually, the fat comes out easier, and it's more, and it becomes more even. You put those fibers under tension, the restricted fibers, and you should loosen up easier. So yeah.
So talking about tumescence, there's always a debate on the secret formula of the fluid. I think from tissue culture, tissue culturing techniques, people have added buffers to it, and other people are using lidocaine, and other people are using adrenaline. What do you recommend, or in your practice, what do you use in your tumescent fluid?
I don't know if I have the best one. I don't know. I don't know if I have the best one, honestly, but I use the simple minimalist one. I use simple saline with epinephrine. I think lidocaine would be good, but my patients under general anesthesia, they really don't need to. But it's good to add something at the end if you want to, and something longer lasting than lidocaine, like Marcaine or Naropin, is a good idea at the end. And sometimes we do that for the patient for their. So, but I think there's a. We're talking about that acid, which really makes sense. A lot of my colleagues, I have no experience with it, so I really don't know. I'm very simplistic here.
I like Angie, what is your secret formula?
I don't have one. It's really it's a learning curve. Maybe the secret formula is really don't underestimate lipofilling. Don't, it's not microsurgery. Okay, it's not something that you that is very gets on your nerves, and you need years to practice, but you also need some know-how to practice it. Don't underestimate it. Really follow the rules. Look at how you harvest, look at how you treat the fat, look at how you bring it in. All these steps are crucial, and if you neglect one of them, you will not reach a result. It's very easy, and you can. Roger is just nodding, but it's really like it. If in the beginning I was like, yeah, but what does he do such a big thing about this or that? And in the end, you learn it the bitter way, follow the rules, and everything just works out. But you really have to follow the rules.
So we're running towards the end, and I think this is a nice bridge, Angie. So I always like to ask people, can people visit you? Can people invite you to present and lecture? But also, what is your advice to people setting this up? We've got people from Africa, from India, from high, low, middle income countries. But what was the step that made you open your eyes and really learn? What is your advice? Roger.
experienced the lowest hanging fruit of fat grafting today is the implant patients. It's my most common operation. It's patients who want to get rid of their implants. They're already expanded, and you can give them a very decent result by downsizing their implant. For the mastectomy patient, I can't go to 0. I downsize. So typically I tell the patient, I'm going to half the size of your implant and double the thickness of your tissues. And if they're not radiated, it takes me 3 steps. And in 3 steps, I can get them to no implant. For the regular cosmetic augmentation, anything in the 300 cc range, I can get them down in very decent size. But there's a technique to do it right. So again, it's all about technique. If you go there with a 10 cc syringe or 5 cc syringe, I injected fat. That's not going to work. You really got to take your time and deliver it. I mean, it took us what, an hour to inject every breast? More than an hour to inject the breast. More than an hour to inject the breast. You can't go fast. It's just, you have to deliver those micro ribbons and micro droplets, and Sid Coleman had it right. And people laughed at him and they say, oh, it took him 7 hours to do an operation. Well, maybe he was excessive, but still, you can't go fast. It's basically microsurgery. It's really fundamental microsurgery. It's micro droplets. Well, I must admit, it's fun to do microsurgery too. But
so your advice is take it easy.
Take it easy. Go on the lowest hanging fruit to remove an implant, and don't go through the original incision. I didn't talk about the implant removal, which is really a separate topic. But do not go through the original. Make an incision outside the breast or in the armpits. Have your finger inside. Make sure you don't graft in the cavity there. Graft 1 layer with the implant in. Take the implant out. Graft a layer in the capsule and the tissue around it, and take your time delivering it. And the patient will have a good result.
Angie, what's your advice
to the starting lipofillers?
The biggest fault that I have seen a couple of times is don't start on the hopeless cases. Many of people think like, okay, this I'm going to do an implant, this I'm going to do a deep, and so on. Oh, but I really don't know what I'm going to do with this irradiated patient that has a BMI of 37 and can't go for big surgery. Oh, then I'm going to start lipofilling. That's not the right patients. Don't start on irradiated breasts. Get for the low-hanging fruit. Get really young patients that are skinny or at least not overweight, and start with them. It's easy to get some fat out of them. Even if you think there is no fat, there is always fat. You will always find something.
Good. So one topic we haven't discussed is the radiated breast. So Angie, you're saying, yes, I do lipofilling in the radiated breast, and Roger as well. Does it come with any extra advice? Radiated tissue?
Take a lot of time, make everything of these fibrous tissue loosen them up. And in my opinion, I leave a lot of time between the sessions. So I tell the patients, okay, this normally it takes for a total breast reconstruction for us about 1.5 years. In irradiated breast, I'll tell them, okay, you're not going to have 3 or 4 sessions. You're going to have 5, 6, or 7 sessions, and it's going to take 3 years. And if you're honest about that, and if you don't expect too much, okay, then you can do it. But you really have to have somebody who's capable to go all the way.
How long between you? Because you're saying I'm taking longer between sessions.
Yeah, normally we leave about 4 months at least between the sessions. In irradiated, I'll leave 6, 7, 8 months between the sessions.
No,
people say that oncologists say you got to wait 6 months before you graft them. And I think there is no science at all behind this. It's unfair to do this poor lady to keep them for 6 months. It's unfair to wait for the fibrosis to settle in, to graft them. Radiation denatures DNA and kills the cancer immediately. The best time to graft them is right when they finish their radiation. Fat actually acts as an anti-inflammatory agent in there. It reduces the inflammation, reduces the fibrosis, and you get much better result if you can graft them right after they finish their radiation. And so in my experience, if I can get them, unfortunately, they're brainwashed, they're not doing it. But if I can get them, my best result, and the one that I was able to really reverse the radiation best, is the one that I got right after the radiation treatment is finished. And typically it takes 2 or 3 sessions to reverse radiation damage. But it's amazing how much we can reverse the radiation damage with fat grafting. But again, you got to be careful. The radiated lumpectomy has a very high rate of recurrence. Whatever you do, just watch them. They're going to have the high recurrence. And so, you got to be watch them very carefully and not just, because they may recur. And a lot of my radiated patients that are fat grafted ended up with the recurrence and had a prior mastectomy. And so it's below what it is expected in the literature, but it's still, having done a few thousands of them, I've had more than a handful of poor ladies who did a beautiful radiated lumpectomy that are reconstructed very nicely, and then they came back. And I tell my patients, ma'am, it's easier for me to reconstruct a total mastectomy that's not radiated than a lumpectomy that's radiated. And so I tell the patient that I care for, if you have a choice, don't get zapped with radiation. Just take it off. I'll give you a nice one, a brand new one, promise you, with good sensation and everything. Much easier than me to correct that radiation defect. The problem here is that the standard is radiation. And in all fairness, most of the radiation do well. I'm a little bit like the child psychiatrist who only sees nuts, kids who are nuts, and to him, all kids are nuts. But I see the nuts. So I see the radiation problem. And I see a lot of radiation problem, but I think the majority of radiation do well.
Okay, well, on that note, I think it's time to round this up. And I would really like to thank presenters today, but most importantly, the people that are watching us. And thanks for everything. I know, Roger, you have visitors every now and then, and Angie and Roger, you both are well known for presenting anywhere around the world, but especially now with Zoom. Be in touch with the people if you have questions. And for now, let's leave it at this. Join us also in the Peru meeting. Next year, we have the first global Icoplast meeting in Peru. I shared the link. Look it up and you're more than welcome. And we'll see you next year in Peru, hopefully. And have what do they drink there? Roger, you must know. Pina colada or anyway. Thanks, everybody, and hope to see you next time. Bye-bye.